So I'm gonna answer a few questions that we had gotten through the Slido, and then I can take some live questions from folks. So is Carol? Yep, Carol's still here. So you win for highest scored question, by the way. Because your question was in relation to if the resident BIMS interview was not done on or prior to the ARD, will the staff assessment be allowed in order to complete the 5-day for HIPS code? I think we've addressed the need in terms of the BIMS and the staff assessment. Again, I think that once the manual is released, the manual instructions will also help to provide a great deal more clarity about that. Because there was also discussion, piggybacking on Carol's question, because if the staff assessment is allowed, will be an allowance for completion after the ARD in the event of unplanned discharges, especially late in the day discharges. I mean, as with anything with the assessments, you want them to be done as timely as possible, and as quickly as possible, so that the information is fresh and accurate. But again, I think we've talked a lot about the BIMS and the staff assessment. Another question that was here and that we've actually gotten a lot in the past is in relation to concordance between the diagnosis that's on the hospital claim versus that which is on the SNF claim or on the MDS. And a lot of this was born out of the fact that when we did our analysis for PDPM, we had to use the hospital diagnosis coding as the basis for our analysis because the SNF coding, quite frankly, there wasn't a great deal of variation in the SNF coding. A lot of it was very generic V codes and things like that didn't provide a great deal of information for us in terms of our analysis. So that's why we used the hospital coding as the basis for the analysis that went into PDPM. But the direct answer is that no, you don't need the claim or the diagnosis that's on I0020B or on the SNF claim does not need to match that which is on the hospital claim because again, there could be different reasons for why you'd be doing it. There were questions about the IPA that, again, in terms of, could a facility devise various criteria for when their facility would complete an IPA? The answer is yes. You certainly can do that at a facility level, or if, as a chain provider, if you want to put it across your company, that's entirely fine as well. Again, it is that CMS is not mandating that you have a certain criteria. It is an optional assessment. One question that actually got 32, the score of 32, was why did CMS use cost reports from 1995 to create payment groups? That's a good question. The answer is because that is what the statute requires. We are required by law to use cost reports from 1995 as setting the base rates. And in order to change that, we would actually need a change in the law. So call your congressman and do that. Another question that actually sort of really piqued my interest was about if provider liable status still existed under PDPM. And it's an interesting question because, as I mentioned earlier, one of the few times, I shouldn't say the only time, but one of the few times that you would get default payment is if you had a late assessment. You can only have a late 5-day assessment. That is, you have an ARD set for after day 8. Provider liable only attaches in the cases where you have a missing assessment. Okay, as under the current policy. And again, given that the PPS discharge does not affect payment, and because the IPA is an optional assessment, you can't mark something for being a missed IPA, you could only really have a missing 5-day assessment. Now, if the reason that the 5-day is missing is because they say discharged on day 3 and you didn't know what was happening or everything was happening so fast. In those cases, Chapter 6 allows for an exception that you can bill default for a period. So the only time provider liability would attach, and I honestly hadn't really thought about this until the question was asked, the only time that you really get provider liability would be if you have a missing assessment and the stay is longer than 10 days. So it means that the person's been in your building for longer than 8 days and you just didn't do a 5-day for them when it was the only required PPS assessment. It shouldn't exist, but it could conceivably. So that is the answer to that question. No, 8 days, sorry. So if they were there for, say, 10 days and you didn't do a 5-day assessment and they've left Part A, then conceivably provider liability could attach. Okay, so yeah, so that was actually another question that we had gotten was the relationship between sort of how this policy affects HMOs, how it affects MA plans, things like that. For all of those questions, the best that I can tell you as far as an answer is to go and speak with the MAO, go speak with the plan sponsor, that they're the ones that are going to have to dictate what their rules are under PDPM. So some of them might be using PDPM HIPS codes and have you report those using the range of, or the 5-day and the IPA. Some of them might ask that you do an OSA and report back a RUG 3 or RUG 4 HIPS code. I know some MA plans are on levels and they don't use HIPS codes at all. They just have other ways of reporting it. So it's a pretty varied bag out there as far as how MA plans work and how private plans work. So the best I can tell you is to contact your plan sponsor and they would be able to give you more information. We also got a lot of questions about things like when is the grouper going to get released, when is the pricer going to get released. There was a question earlier about the claims processing manual. Again, the best I can tell you at this point is that all of those are things that we are working towards. I will be, and this is not, I'm not trying to blame anyone, but oftentimes we get very, very good questions from all of you that cause us to change something in what we're doing. Especially the SAS grouper has been updated a number of times due to really great comments and questions that we've received about the ICD-10 mapping. Or issues in terms of the programming. And so the same thing happens with the other grouper, with the actual DLL and that we're working toward. So all of those are in process. We really do hope and are trying to get them out as quickly as possible. So stay tuned for that. But I can't provide any specific date that those will be released, but we are trying to get them out as soon as possible. Let's see. All right, there's a lot of other questions. I mean, there's a lot of questions, and I think we need to figure out how we're going to be addressing these. I think a lot of the questions that were on PDPM, because someone also had asked at one point, I don't think it was my question, but it was more of a general question on where can they find some of these. I think that one of the things that I think our team is going to do definitely is take the questions that were asked here on PDPM, take those back, and you can expect that they will likely update our PDPM FAQ document to reflect a lot of the questions and answers that we're giving here. Because I know one thing that people say is, John Kane said this at a meeting, where is it though? And so I understand that that's much better than having me say it, and so we will try to get our FAQs updated to reflect these questions. With that, I mean, again, there's a lot of other questions here, but I'm just going to kind of kick it open. If anyone has other questions that they want to ask or anything that's concerning them about PDPM implementation or anything that we can take back. Bridget has a question. Oh, okay.
I'm kind of getting back to that pesky question about the BIMS, the interview versus the staff assessment for the BIMS. If neither happens, it's after day 8. We don't get a HIP score. Is that going to be another case of where it would be coded in billing as a provider liable? Because we're still going to have to take the residents' days are still going to count against them. We just won't be able to bill anything, correct?
Right. So in the case where you don't have an assessment in the Keys ASAP, and so it's a missing assessment, and it is not something where the stay is 8 days or less, then yes, that would be an instance of provider.
It's a missing piece, right? I mean, it's just the missing interview
right.
Or staff assessment, so that component has not been completed.
Right, but so
it's considered a missing assessment, and it's
without a HIPS code that's produced on the assessment, because one of the basic billing rules that does continue to exist from RUG 4 to PDPM is that in order to be able to bill on a claim, you have to have an assessment HIPS code that you can then put onto the claim, and they have to be able to match. That actually reminds me of another question. I'm sorry?
That those days would still go against the residents' 100-day stay.
Right, but if you don't have the HIPS code to be able to bill, then there would not be nothing to be able to put on the claim, and so that is the key component that is missing. at that point. Which I will say, that did remind me of something that people had asked a lot, was in relation to HIV and AIDS, that if the pricer is handling everything, what is the HIPS code that's going to be reported on the claim? Like, do you manually add it and then put that HIPS code on the claim? And the answer is no. The HIPS code that goes on the claim is that which is produced by the assessment. That is very important that you use the one that's produced by the assessment. The pricer has embedded in it two aspects in relation to HIV and AIDS. The first is the more simple one, which is the 18% add-on. So that's just, take the nursing rate, multiply it by 1.18, you get the new nursing rate. For NTA, it's a little bit more complex, but basically there's a correlation between the group that you're in without the 8 points and the group that you are in with that 8 points. And so if the B20 code is found to be present, the pricer will, in a sense, take the rate for the new NTA component, and that will be the one it uses in terms of calculating your PDPM rate. Okay, but again, the one you want to report on the claim and the one that's produced by the assessment. And this goes back to the question that someone had asked earlier on, for those states that do allow that reporting, is the grouper going to account for it? And the answer is no. The grouper is going to completely ignore any AIDS or HIV diagnosis on the assessment. And it'll only be that's what's reported on the claim, and the pricer will do its work.
Hi, my question is in regard to the section GG. There are several interpretations out there in regard to if the patient has benefited from therapy as to whether or not you can count the entire 3-day window. Mm-hmm. Can you comment on that a little bit?
I cannot. I would unfortunately. Anne's got it. She'll take care of it. Thank you.
Other PDPM questions?
Other PDPM questions that are not from Carol? This might be my last one, and it's going to be the one I can't answer. So
This is an easy one, and I'm just confused.
don't say that.
Okay. On and over assessment, is the RUG, it's not going to be a RUG, is that going to be reporting a RUG 4, or is it going to be reporting PDPM?
So my understanding is that on the OBRA assessments, that in one of the systems that we have, states tell us what they want reported in the basically in the RUG code. And so the current OBRA assessments, and even the OBRA assessments as of October 1st, will not be able to calculate a PDPM code. One of the main things that's missing is section GG. So we are hoping to get to that point, which reminds me of another question. We are hoping to get to that point soon, but they won't be able to produce a PDPM HIPS code. So they would produce whatever HIPS code is in the system that the state wanted to report, whether it be a RUG 3 code or a RUG 4 code.
And so are states doing different things?
So states for them are currently in a sense of in a holding pattern. They're going to be maintaining their use of legacy payment models such as RUG 3 and RUG 4 for the time being. Several states have approached us saying that they are very interested in considering a transition to PDPM. Some have actually said that they're specifically focused on the nursing component for PDPM because they already have other means of addressing therapy and NTAs. But again, the key element that's missing in that is section GG. So until we're able to get section GG, we're definitely maintaining our support for these legacy payment models. And then once they have that, they'll need time to collect the data and things like that. So that's why the OSA will continue to exist so that we can continue to support that.
In the original information about HIPS code, it gave an option of a 6, and I saw that that's now missing. Is that you can't replace a missing PPS assessment with an OBRA? Is it because you can't, because there's no GG? So it was a 0
Right.
for this,
Yes.
a 1 for that, or a 6?
Right. There's
Six is missing?
So currently, an OBRA assessment, let's say an OBRA admission assessment, could produce a RUG 4 HIPS code that you can then use to bill for, I think it's like 1 period or 2 periods. Right. So because the OBRA assessments are not able to produce that HIPS code, there's no way of allowing for the OBRA to supplant what is a missing 5-day assessment.
Yeah, the issue I see is sometimes we are not aware that someone is Medicare.
Right.
Because they've been in HMO and they disenroll.
Right.
And they're off before we figure it out, so there would not be a way of calculating, in that case, what would happen to Medicare payment for the surprise or Medicare people?
So this is where, I mean, what I've been told by various providers in terms of how they handle situations like that is, like for people who have been on MA or things like that, that they've completed the PPS schedule along with it, or even just opened the assessments to have the ARD set, so that, you know, if that were to occur, which my understanding is it actually happens more frequently than I may have thought, that they're covered and they have the assessments open and the ARDs set so that they're able to complete them when necessary. Other than that, again, without having the relevant items on the OBRA assessments, there was no way for us to be able to match with what the current system allows for in terms of RUG 4. But we do hope at some point we'll be able to do that.
Thank you.
All right, I'm going to turn it over to my colleagues who will then answer. Oh, I'm sorry. Okay, one more question. Go ahead.
Where's the question?
We have one question right here. An NTA question? Okay.
And then we are at time, John.
Yes.
So on the NTA comorbidity score calculation, and I'm going to give an example.
Okay.
Like, for example, active diabetes, it's coded in section I. We checked it, it's coded.
Mhm.
You get score there, right? Do we also check that under specified hereditary metabolic immune disorder? Because diabetes is type 1 would be a hereditary immune disorder also. And both metabolic. Same thing as asthma.
That is a good question. I don't know the answer to that question.
So are we going to get a release of maybe what are the lists of diseases for some of those?
Right, so that's a good question. I have to think back to whether or not there's anything more that we say in the manual that gets into that as far as each of those. I don't know. That's something that I think we can take back and we can probably address it through an FAQ. So that's a really good question, though. Thank you. Sorry to leave you with an I don't know for the last question. So, all right, thank you, everyone.
Okay. So I have a question here that says a surveyor at a facility states that section GG items should have been signed off on Z0400 on either day 1, 2, or 3. The MDS coordinator signed off on day 5 after collaborating and reviewing documentation from the first 3 days. Unlike interviews, GG items require supporting documentation. So per the RAI manual, all staff who completed any part of the MDS must enter their signatures, titles, sections, or portions of sections they completed and the date they were completed. So in this example, the person who completed the items in section GG is the person who should sign at 00400 with the dates that the items were completed. Next question is each facility required to have a policy regarding when to do an IPA? What's the answer? The completion of the IPA is entirely left up to the discretion of the provider. If the provider wishes to create a policy related to completion of the IPA, they are free to do so. However, CMS does not require such a policy. Can multiple IPAs be completed for a stay? The IPA is an optional assessment, completion of which is at the discretion of the provider. What is the default HIPS billing code? It's ZZZZZ. If a facility inadvertently does an IPA that decreases payment, can that IPA be inactivated and the bill adjusted if discovered after the claim is billed? Again, the IPA is an optional assessment, completion of which is at the discretion of the provider. Okay, and I think just to tack on a little bit to what John spoke about regarding using the OSA for Medicare Advantage plans requesting rugs. In addition to contacting your plan sponsor regarding that, I think you could kind of almost think of like what you were doing before. You know, you can complete, there's no reason why if your software can take in the OSA and give you a rug, that you can then give that, but you're not going to submit it. Because if you try to submit that to Keys ASAP, it's going to end up in the state daily assessment extract file, which the states use to calculate Medicaid case mix. And if they got a resident in there that is not a Medicaid person, they probably would not be very happy. So I would think that if your software can calculate that, that you can use that code, the RUG 3 or 4 code from that. Just don't submit it.
Thanks. We have a few DRR questions. Why is N 2005 counting the issues identified upon admission again if it is already captured in N 2001 and N 2003? Why not have N 2005 only count after admission through discharge? The intent of N 2005 is to address all potential or actual clinically significant medication issues throughout the stay. This includes the data collected upon admission, N 2001 and N 2003, and at any time throughout the resident's stay. Who is to complete the admission DRR? What is considered acceptable documentation in the medical records? CMS does not provide guidance on who can complete the DRR. Facilities should refer to their best clinical practices, facility, state, and federal policies and procedures to determine which SNF staff members may complete DRR items at your facility. Each facility delivers resident care according to its unique characteristics and standards, for example, their resident population. Thus, each facility self-determines its policies and procedures for completing the assessments in compliance with state and federal requirements, and data in the MDS should be consistent with information in the medical record. Are there any exclusions for DRR? How are dashes calculated for this QRP? In the QM User's Manual version 2.0, there are no denominator exclusions for this measure. If a dash is entered for any of the 3 data elements, it will not be included in the numerator count. Stay definition for QRP measure. If a resident is discharged from a Part A stay but returned for a continued stay related to an interrupted stay, so what I believe this person is asking is if in the case of an interrupted stay, would these be 2 stays for QRP purposes? The answer is no. For the purposes of the SNF QRP, this would be a single stay. The provider would code A0310G1, is this an interrupted stay, as yes, and if AG0310G1 equals 1, yes, then A0310H, which is this a Medicare Part A PPS assessment, would be no. Please clarify, what are the assessments involved to be captured in the assessment-based quality measures? Is it limited to PPS assessments? For most assessment-based quality measures, the assessments used in the calculation of the measure include the PPS 5-day and the Part A PPS discharge, or both. However, for the measure falls with major injury in the QRP, this measure uses the PPS 5-day, the PPS discharge, and all intervening PPS and OBRA assessments between the 5-day and the discharge. And please refer to the QM presentation and the QM User's Manual for details on each of these measures.
Hi, everyone. I'm going to be answering questions on section GG. So the first question is, if the facility policy is to always use gait belts when going from sit to stand, is it always coded 03? Our answer is no. When coding sit to stand, code based on the type and amount of assistance provided. For example, if no more than steadying or touching assistance is provided from one helper, then code sit to stand 04 supervision or touching assistance. If more assistance is required, sit to stand could be coded 03, 02, or 01. The next question is, in the event you have multiple entries in the 3 days we assess GG functional status, what frequency would be considered usual? When we defend the documentation, how will we defend against opinions without a quantitative definition? And our answer is, when coding section GG activities, only consider instances when a clinical assessment of the resident was conducted and the resident was allowed to function as independently as possible. Do not record the resident's best performance and do not record the resident's worst performance, but rather record the level at which the resident could consistently perform. Next, we have toileting hygiene states wiping, opening, but not managing equipment. Does coding this item include the ability to empty the device and manipulation of the opening or closure? And our answer is no. For a resident with an ostomy, when coding toileting hygiene, only consider wiping the bag after emptying, which would be equivalent to perianal cleansing. Next, we have for bed mobility, how is this coded if a resident sleeps on alternate bed furniture, such as a couch or a recliner? If the resident uses a recliner, sofa, or mattress on the floor as the resident's bed, which is their preferred or necessary sleeping surface, assess the resident's need for assistance using that sleeping surface when determining their ability for bed mobility items. And that's GG0170A, roll left and right, through GG0170E, chair, bed to chair transfer. Finally, we have how should we code the admission assessment for section GG if the resident has started therapy? If the resident performed the activity during the 3-day assessment period, code the activity based on the type and amount of assistance needed by the resident during the assessment period. The exception is the instance when the resident has significantly benefited from the implementation of the treatment plan by the 3rd day. It should be rare to use an activity not attempted code if the activity, occurred during the first 3 days. Thank you.